Welcome, everyone. I am Amanda Egan, the Director of Patient Engagement and Clinical Programs with the Runxon Research Program. And I'm here to kick off the webinar, Introduction to the Stem Cell Harvesting and Baking Clinical Trial for subjects at the Children's Hospital of Philadelphia. We're delighted to have the study lead here to speak about the trial, its goals, who is eligible, and what a patient can expect when participating. Dr. Tim Olson is a physician and researcher at the Children's Hospital of Philadelphia, or CHOP, as you'll hear us refer to it. He specializes in pediatric hematology and oncology with a clinical focus on bone marrow failure syndromes and inherited predispositions to leukemia. Dr. Olson has a passion for helping families with RUNX1 FPD. So RRP has had the privilege of working closely with Dr. Olson for several years. He's been a trusted advisor for our medical education program, presented to our patient community, and played a pivotal role in launching this stem cell harvesting and banking study, which you might know first opened up about 6 months ago at MD Anderson Cancer Center and is now open at CHOP as well. So this project, developed in close collaboration with Dr. Katrine Erickson, our executive director, is a groundbreaking effort to evaluate the feasibility of collecting and banking blood stem cells from individuals with RUNX1. The study's ultimate goal is to lay the groundwork for future gene editing therapies that could transform the lives of patients. So Dr. Olson's commitment to advancing care for RUNX1 families shines through in every aspect of his work, and we are delighted to have him with us today. So please note that Dr. Olson has prepared his presentation specifically for a patient audience. We do know and are grateful that we will have clinicians and scientists with us here today. We will try to prioritize patient questions first, but feel free to pose questions that you have if you are from these other groups. In terms of asking questions during the session, since it is webinar format, we won't be able to hear you, but during the presentation at any point, you can open up the Q&A icon, which you should be able to find at the bottom of your screen, depending on the type of technology you're using. But if you open that up, you can type in a question, and we're doing our best to keep you anonymous if you would like. So you can actually select, there's a checkbox where you can select ask question anonymously, and then your name won't appear to us. Regardless, your name won't appear to anyone on this call. Let's see, we encourage you to ask anything you have. Of course, any questions you might have, others might be wondering. Please do recognize that the presentation contents and responses should not be considered personalized medical advice, of course. So I think that's it from me, and I will stop sharing and let you, Dr. Olson, share your screen and get started. I guess I should say at the very end, after his presentation, I will pull up the Q&A window and begin reading out your questions that you have for Dr. Olson, but feel free to type them in at any point. And I can see your screen. I don't see you in presenter mode just yet, but I see your screen. Perfect. Okay.
Good to go now. Is it in presenter mode? Perfect. All right. Well, thanks everybody for attending this webinar, and I'm very grateful to Amanda for inviting me to speak today about this trial, which opened a couple of months ago here. As Amanda mentioned, this is a parallel study to the one that's being run in MD Anderson. And the title of the clinical trial is Safety and Feasibility of Autologous CD34 Positive Hematopoietic Stem Cell Mobilization Apheresis in Participants with RUNX1 Familial Platelet Disorder. We will explain what all of that means as we go through these slides. These are my disclosures. So where the origins of this study are really coming from is the recognition that for many other genetic disorders of blood cells, we are now beginning to apply stem cell-based gene therapy to the clinic. Gene therapy has been a long time in coming to the clinical world. The early discoveries in the 1980s of specific genes that were underlying developmental blood cell disorders led very soon after to early trials to try to correct these genes using a variety of different technologies. A lot of these technologies are listed here. But it's really been in the last 10 to 15 years where the success of clinical trials of these gene therapy have led to the generation of now FDA-approved commercial gene therapies. And at CHOP, we're proud to be the only center in the United States that is a qualified treatment center for all 5 of the stem cell-based gene therapy products to correct blood disorders and 2 metabolic disorders as well that can be corrected through stem cell transplantation. This isn't the future any longer, right? Stem cell-based gene therapy has really arrived. And for those genetic disorders where there may not be a gene therapy yet, rest assured that there are a lot of folks behind the scenes thinking about the optimal ways in which to be able to develop gene therapy for patients. So what does gene therapy look like? Well, first of all, compared to a typical type of transplant that's done for blood disorders, which is what we call an allogeneic transplant, the one step that is different is we first have to collect the stem cells from the patients themselves. Because this is the material that's then used for the gene correction to fix the underlying blood disorder. Once that correction has occurred, once the gene therapy product, which is a combination of the molecular machinery, or in some cases it's viral vector, that are used to gene modify the cells and the cells themselves. But once the gene product has been manufactured, then the cells come back for us. And what we do with that is we do an autologous transplant using less intensive conditioning than we need for allogeneic transplants, with lower risk of immunologic complications as you go through the transplant. So that's the benefit of an autologous transplant done for gene therapy. There are 2 general strategies for how we go about gene modifying your own stem cells for a gene therapy product. One is, as I mentioned, you put in a copy of the normal gene using lentiviral transduction. And then the second technique, which has really evolved year to year in the last 5 to 10 years, are different mechanisms of getting in and breaking the DNA to correct the mutation directly, or to disrupt a regulatory element in the genes. And classically, this has been done with CRISPR-Cas9 technologies, but there are newer technologies that are coming on board every day for this gene editing, and it holds the promise to be able to individually correct gene mutations in disorders where there can be mutations throughout the length of a given gene. The challenge with applying gene therapy, though, to disorders that predispose to the development of leukemia, such as RUNX1-FPD, is when is the ideal time to pursue that gene therapy, right? So for patients who have a predisposition syndrome like RUNX1-FPD, early in life, they're in the state known as germline predisposition. Their marrow is healthy. We don't see clear evidence of abnormalities in blood cells, but we don't yet know if they're going to go on to develop disease in the future. In between, there is a state where one develops myelodysplastic syndrome, where there are already mutations that have occurred in the bone marrow stem cells, bone marrow progenitor cells, that lead down the path of acquisition of more mutations to the development of leukemia. So for gene therapy for myeloid malignancy predisposition syndromes, we really need to catch the stem cells for modification at a time before they've started to acquire the mutations that lead to the development of myelodysplastic syndrome. So preventing myeloid malignancy in patients with RUNX1-FPD is a controversial topic. And a topic for another day is the idea of doing preemptive allogeneic transplant, which has come up in several discussions, including at the RUNX1-FPD meeting in New Jersey this past fall. The issue is if you perform an allogeneic transplant very early in the disease course, you're likely subjecting patients to the risks of transplant before you know whether or not they're going to develop myeloid malignancy, right? So you're transplanting some patients who might have never needed it otherwise. And because of a lot of the risks of going through a conventional allogeneic transplant, including risks like severe graft versus host disease and mortality from the immunologic complications of trying to get somebody else's stem cells to work effectively without toxicity when they are transplanted into you, the risks of mortality, the risks of severe morbidity are simply very high to perform preemptive transplant in everyone. However, if you wait until after clonal disease onset occurs, this may be too late for optimal outcomes. And furthermore, with allogeneic transplant, if you wait until patients are in mid-adulthood, some of their potential donors, such as family members, haploidentical donors, sibling donors, may no longer be suitable donors at those older ages. And so that's a big challenge in deciding what the optimal time for allogeneic transplant is in RUNX1 FPD. But gene therapy has its own challenges. So when you're thinking about gene therapy, as I mentioned in the last slide, we have to think about collecting the stem cells before the onset of premalignant clonal disease occurs. But maybe we don't necessarily need to subject patients to the risks of transplant until we know that it's needed, until they have developed biomarkers which suggest that they're at high risk for developing MDS. So if we could develop therapies where we can collect stem cells early on in the lifespan of patients who have RUNX1 FPD, where the stem cells are healthy and without significant mutations, we'll get into that in a little bit, that may afford the ability to use those stem cells for gene therapy applications once they're developed in the future. And then lastly, the barrier to gene therapy is we need scientists and researchers to work on developing successful gene editing techniques that are specific to RUNX1 mutations, right? So we need stem cells available for the research community to be able to work on these projects. So that brings us to this study, which at CHOP is study 24B-T081, the safety and feasibility of collecting stem cells by mobilization and apheresis, and I'll explain both of those things in a minute, in patients who have RUNX1 FPD. The study team at CHOP includes me and then Nora Gibson, who is a very talented junior investigator who is leading much of this study for us. And then we finally became activated with this study after several years of working on it as of November 2024. So we are collaborating with the team at MD Anderson on this protocol, but it's very important to understand how we're collaborating with them. So we developed our protocols in parallel. There are slight differences between the protocols. They are not a joint protocol. So the protocol that we have open is only opened at our center here at CHOP. And the protocol that's open at MD Anderson is also only open there. We are agreed to combine data, though, to learn from each other's experiences in what we call a learning cooperative. And that learning cooperative has been facilitated by the great people at the RUNX1 research program. So the objectives of our study, the primary point of this study is to make sure it is safe to harvest stem cells by the process of apheresis in patients with RUNX1 FPD. And specifically, we're going to be looking for the frequency and the severity of adverse events for the patients who go through this, right? This will never become a clinical practice if there is a high frequency of challenges that come up in the patients that are going through this protocol. The secondary objective of this is to evaluate the feasibility of being able to collect enough stem cells from patients with RUNX1 FPD for a couple of different purposes, right? So first of all, we want to make sure that the patients that we screen are actually able to proceed to the intervention, which in this case is the apheresis collection of the stem cells. The second is we want to figure out the number of the patients who go to apheresis and whom we're able to achieve a minimum number of stem cells, which is 2.5 million cells per kilogram of body weight. This upper number is the number of stem cells that we need to have stored in the event that when a patient does develop malignancy when they are older, and perhaps they don't have a suitable allogeneic donor for an allogeneic transplant, we have some of their own stem cells that we could potentially give back in an autologous transplant setting, what we have referred to as an autologous reset. Right? So we want to be able to figure out the number of patients that go through this collection that we're able to get that dose of stem cells from. The second objective is to figure out the number of patients that get enough stem cells mobilized and collected that it would enable a gene therapy product to be made once that technology is available. And knowing what we know from other gene therapy studies that we participate in, we know that that number that is required by all of those companies that are making commercial gene therapy products now is 15 million stem cells per kilogram of body weight. We also want to know how many days of collection it is going to take to achieve this goal. We're hoping it can be done in one, but we're willing to go out to a couple of days of collection to see, to figure out exactly how many days it is going to take to get to that stem cell number. So at CHOP, we plan on enrolling 6 patients, at least at present, based on the current financial support of the study, and we're open to expanding that in the future, depending upon the level of interest from the community. One of the key differences in the CHOP protocol versus the MD Anderson protocol is our institutional review board only approved at the outset doing this stem cell collection in patients that are adults. So that means patients that are at least 18 years of age. And this was a slight difference in the review from what was done at MD Anderson. The rationale of our IRB was that we need to make sure that this has proven safety before we can move into children, because children have the ability to assent according to current laws, but they don't have the ability to provide consent. And as a consequence, the standard for proving the safety of an individual intervention has to be higher in children versus in adults. So we have to prove that this is safe in consenting adults before we can move this study into children. And then there's another element of this to see whether there ends up being a prospect of direct benefit, and we can talk about this in the question and answers if you're interested, to be able to consent and assent to children under the age of 18 for a study like this. So the study has 3 phases. The first phase is the screening phase. The second is when we actually collect the stem cells, which is called mobilization and apheresis. And then the third phase is what we do in follow-up, relatively long-term over the period of 2 years, to make sure that going through this intervention was safe in the long run for patients. So in terms of the screening, if there is a patient who is interested, we invite you to come to CHOP. We would go through the consent document with you, and then we would draw a set of standard laboratory evaluations, and those laboratory evaluations are listed here. I'll highlight a couple of things. One is we have to make sure that the testing for the RUNX1 germline mutation is confirmed, and so that's critical. We also need to test for the presence of any acquired mutations in the bone marrow that might be consistent with advanced or advancing disease, such as MDS. We have to make sure that those mutations are not present. We're also collecting stem cell counts in the blood at baseline, although that's not used for eligibility. We're looking at certain infectious disease markers. We're looking at blood counts. We're looking at organ function, such as kidney function and liver function, as we go through. So this is the table on the left is another set of a way to look at the evaluations that we're doing during the screening phase. We get consent, we take medical histories, we make sure that you meet inclusion and exclusion criteria. And then we send these labs and evaluations. We also do EKGs to make sure that patients are safe for apheresis collection. An EKG is a rhythm strip of the heart rhythm to make sure that patients are safe to go through the apheresis. So our inclusion criteria include the ages listed here have to be 18 or older. You have to have the confirmed diagnosis of RUNX1 FPD. Our apheresis team has to evaluate you and make sure you're cleared to undergo the process. You can't have uncontrolled high blood pressure. You have to be medically fit through an assessment that we do called a performance status, and we do that sort of very quickly within a couple of minutes in the office. You can have thrombocytopenia, but you can't have a platelet count less than 50,000. And the reason for that is the process of apheresis can lower platelet counts. If your baseline platelet count is less than 50,000, then we have to think about the pros and cons of administering platelets at the time that we do the stem cell transplant. And then hemoglobin values have to be over 7.5, which that should not be a problem for most patients. Things that would exclude you from being eligible for this study include a diagnosis of MDS or other hematologic malignancies, other solid tumor cancers that have been diagnosed recently or treated recently within the last 5 years. I'm going to get back to this point in yellow on the next slide, but the presence of clonal hematopoiesis without MDS, it depends on what we assess your risk of going on to develop MDS to be, and we'll talk about this on the next slide. You can't have uncontrolled bleeding or a significant coagulation disorder beyond the platelet deficit that occurs in RUNX1 FPD. You can't have an immune deficiency. You can't have severe organ dysfunction. You can't have already undergone a transplant in the past. Some of that infectious disease screening could make patients ineligible as well. Pregnancy is a contraindication or lack of adequate contraception because we don't know the effects of some of the mobilization agents on individuals who are pregnant. And then any condition that prevents the understanding of consent or ability to complete the study procedures. All right, back to the highlighted point from the last slide. We now know from work that was supported by the RUNX1 Research Foundation and published by the NIH group, Dr. Liu's group, that a large percentage of patients with RUNX1 FPD who have not been diagnosed with a hematologic malignancy will have evidence of clonal hematopoiesis. There will be mutations that have been acquired in genes within bone marrow stem and progenitor cells. This publication suggested up to 50% of patients will have these genetic changes. Others have suggested that it's at least over 30%. So we know that a third to a half of patients that might be eligible for this study might have a single mutation. And the way that we're thinking about this, the protocol is written that we have clinical discretion, and the clinical discretion that we are likely to apply is if we see a mutation that specifically has been associated with high risk of transformation into MDS, or if we see a pattern that has been associated with that, we are likely to say it's not in your best interest to proceed with this collection protocol because the likelihood that we would use that product long-term once there was a gene therapy available to make a gene therapy would just be low. And thus, we wouldn't want to put you through the study interventions if that were going to be the case. So examples of this include any second hit RUNX1 mutation, any cytogenetic changes, such as monosomy 7, and any combination of some of these single gene mutations as well, suggesting that a clone is becoming complex and heading towards MDS would be the things that we would be talking about excluding. So the mobilization and apheresis phase, let me take you through this really quickly. So if you pass through the screening phase and are ready for therapy, the therapy would be done here in Philadelphia and would start with 3 days of mobilization. And we're going to use a medication called GCSF, which is administered subcutaneously once a day for 3 days. We'll talk about the side effects of GCSF in a couple of slides. Sometimes we provide teaching for you to give this at home. Sometimes we actually just have you come into our office. It takes an hour or less, and we can administer the GCSF as well. On the fourth day, so what GCSF does is it pushes stem cells out of their bone marrow niches and causes them to circulate through the bloodstream. And that circulation through the bloodstream makes them accessible for us doing the process that is known as apheresis. On the fourth day of the mobilization, if our apheresis team has deemed that your access in terms of how good your peripheral veins are on your arms in particular isn't suitable to be able to get the size of IVs in that we need for apheresis, we would recommend placement of a central venous catheter. That central venous catheter is temporary, would be in place for just a couple of days. And this is all part of the study. So these aren't medical care costs to you that have to go through insurance. This is a process that's being paid for by the study. We would put in this catheter, and it would go in the neck here to one of the larger veins in the neck. And that catheter has two sides to it, so we can use it for apheresis. So day 5 is the apheresis process, and I should have included a picture of apheresis in these slides. I apologize. I think I accidentally omitted that slide. But apheresis is a process where blood is drawn out of one side of this catheter or one IV if you're deemed suitable to do this with a normal IV. It is circulated around a system that allows us to filter out the stem cells to be collected, and then it passes your blood back to you through either the other side of the central venous catheter or through an IV that's placed in another arm. Okay. So that apheresis day starts with administration of the last day of GCSF. If by looking at the number of stem cells that we have in the blood after we've given the first 4 days of GCSF, we think the number of stem cells is too low, we may give you a second mobilizing agent as well called plerixafor to try to push more stem cells out, and that would be done the morning of the apheresis collection. For apheresis, you are connected to the apheresis machine for a period of about 2 to 3 hours, usually. And that is when they're sort of circulating your blood in and out to try to collect as many stem cells as we can. By the end of the day, we're able to get a cell count of the number of cells that we've collected. And if we've collected our goal, in discussing this with you, we might well be done by the end of that day. And if we've placed a central venous catheter, we would remove that catheter at the time. So that would be the end of the process. If we think that we've collected some, but we're in agreement with you that you would like to see if you could get to a higher level for a second day of collection, we may have you stay overnight in the hospital that night. And again, that's paid for as part of the study. And then we would resume the GCSF, perhaps the plerixafor, and then the apheresis for a second day. So we might do as many as 2 days of collection for the apheresis. Once that line is out and once we're done collecting the cells, we would have you come back for follow-up. And the first follow-up assessment is designed to be done between 1 to 2 weeks after the apheresis. And this is really a safety check-in to make sure you're feeling well, to make sure blood counts have gone back into the normal range. The second follow-up is done 3 to 6 weeks after the apheresis. And again, this is to make sure that blood counts and blood stem cell levels have returned to normal range and to make sure you haven't had any ongoing adverse events from having gone through the collection procedure. The last pieces of this are screening bone marrow aspirations and biopsies, which we do at months 6, 12, and 24. The months 12 and 24 assessments, we actually think would be part of your routine standard care for monitoring for clonal changes in the bone marrow. And so those can actually be done at your local center. It would be the month 6 marrow that we would want to do here at CHOP. These are some of the side effects of using the GCSF medicine for mobilization, and the way that this table is broken down. To the left are the things that we expect to happen in at least about 10% of people. In the middle, 1 to 10% of people might experience these side effects, and in the right, these are very rare but serious side effects that can occasionally happen. And I've highlighted a couple of ones that we think about. Going through GCSF and the process of apheresis can lead to lower platelet counts, which I already mentioned. And then the biggest side effect that most patients experience with GCSF, particularly by the 4th or 5th day, is pain, musculoskeletal pain. And this is actually, in a way, a sign that the GCSF is working, because GCSF pushes cell growth and mobilization of cells out of the marrow, and that bone pain seems to be part and parcel of that. We have a few different things that we can do to help manage the bone pain, but that, I would say, would be the most common side effect that we see. The other thing that we worry about with GCSF is the spleen. In patients who already have significantly enlarged spleens, we worry that GCSF can cause the spleen to grow more, and even very rarely lead to splenic rupture. And so this is one of the reasons why patients who have severe splenomegaly are excluded from the study. And then very rarely also we have patients who have had allergic reactions to GCSF. Plerixafor is the second mobilization agent, and this is listed here. GI side effects and injection site reactions are the most common things with this. Also, rarely can we see allergic reactions to this too. Additional risks to think about: the process of apheresis itself is associated with a few medical symptoms. Again, because of lowering of the platelet counts, we can temporarily see an increase in bleeding. GI side effects, flushing, lightheadedness from the fluid shifts that come along with apheresis are relatively common, as are electrolyte disturbances. So we often monitor electrolytes closely as patients go through the process of apheresis. Some patients will have some muscle cramps as well. Very rarely, these electrolyte disturbances can lead to heart rhythm abnormalities, which is why we screen EKGs. And then anytime you put in central venous catheters, there's a risk of infections. Anytime you change electrolytes, there's a theoretical risk of seizures, but those are expected to be very rare with apheresis. Central venous line placement, if it's required, is associated with risks as well, and you would talk with the interventional radiologist who would place this line about those risks. Bruising and bleeding, the catheter penetrating the chest space instead of staying in the blood vessel can cause lung issues. Also, catheters can be associated with infections and clots. All of these, fortunately, are very rare, but they can be very serious. And so, anybody interested in this study, would need to consider these risks and know that though the likelihood of them is quite low, they're not zero. Okay. The safety analyses that we're thinking about related to this study include the proportion of patients who are able to complete the mobilization, the proportion of patients who complete apheresis, and then collection of all the adverse events, laboratory values through 30 days after the collection as well. And certainly, if any patient, for any reason, whether study related or not, happens to not survive the period of study follow-up, which is 2 years, that's a critical part of this safety analysis. Okay. Enrollment would be temporarily suspended if any patient who is on this study has any cause of death whatsoever during the study period. Anybody who develops an early hematologic malignancy diagnosis after 6 months within undergoing collection, because the concern there would be if going through the mobilization triggered stem cells to acquire more genetic hits leading to hematologic malignancy. And then any significant toxicities, and we call these greater than grade 3, which is how we score toxicities, any toxicities to the mobilizing medication or going through the process of apheresis itself. So lastly, I just want to mention how we will keep the collected stem cells and what they'll be used for. So we're going to prioritize first having a bag that would be sufficient to be able to have an autologous stem cell collection for that autologous reset purpose that I talked about towards the beginning of this talk. So that is, if we collect less than 5 million cells per kilogram, that is what we're going to prioritize first. If we collect between 5 to 15, then we're going to collect not only that unmanipulated graft, but we're going to also store a separate graft that could be used for a potential future gene therapy product as well. And then it sort of goes up from there. If we're successful at collecting more stem cells, the number of bags we're going to be able to collect for gene therapy. And then any cells that are left over that don't fit into these aliquots, we're going to collect in smaller aliquots that can be released for researchers who are studying techniques to develop gene therapy for RUNX1 FPD. And the last qualification that I'll make is that in the event that a study's participant cells no longer will be used to develop a clinical product, so if a patient releases them, if there is a participant death, if a participant signs the release, or if they're lost to follow-up or contact after greater than 15 years, any of these cell products could potentially be de-identified and released for the use of research to find better techniques for gene therapy and better cures for RUNX1 FPD. With that, I just want to acknowledge all of the folks that have participated in our program. The ones highlighted in yellow will be key contributors to this particular study. And I would love to take any questions that the audience has. Thank you very much for your attention.
Thank you, Dr. Olson. That was really, I've been learning about this study for a while, and I always learn something new with every presentation. So thanks for all that detail for me. There are a number of questions, and I'll just start to read them out to you. So I think you may have answered this later you definitely answered this later, but will patient stem cells be kept for them and available for gene editing if science evolves and it's feasible in the future if the patient goes on to develop cancer, or is this stem cell banking just for research purposes? I think that table pretty much answered that at the end there. But
yes, absolutely. We wouldn't be doing this if this were just for research purposes. I think there are other ways to collect small amounts of stem cells in patients for the research purpose. The primary goal of this study is to prove that we can bank large enough populations of cells, not only to facilitate that regular routine autologous transplant that we're calling the autologous reset, which requires a smaller number of cells, but also to be able to bank enough cells to be able to say, we have these frozen cells from this patient, and we can use this to make a gene therapy product once that technology is available. So that's that's one of the big goals of this. Now, one of the controversies, I will say up front, is a lot of the commercial therapies right now that have been developed for diseases like sickle cell disease and thalassemia major, they are wanting the cells to be collected fresh at the time that you're going to manufacture the gene therapy product. And so as of right now, that has been the preference. But there are a couple of companies in that space that are starting to do this with frozen products. And I think the wave of the future, particularly if gene therapy is going to be applicable for patients who have these cancer predisposition syndromes, is we're going to have to be able to do that, right? We're going to have to collect the stem cells when the patients are young and there are no clonal abnormalities, and store them, and then manufacture the product when and if it's needed later. So I think that's a poignant question. Sorry, it took me a while to answer it, but I wanted to emphasize how important that question was.
yeah, thank you. No, that was really clear. Thank you. So you had mentioned the somatic hits and other mutations that might exclude individuals, or you might consider discussing whether that they should be excluded. But there was a question around whether a RUNX1 mutation or a RUNX1 patient with a deletion might be ineligible. What are your, I don't think that's a problem, right? But how does that factor into decisions here? Do you have any thoughts?
I'm going to answer this in two ways because I'm a little uncertain what's being meant by the RUNX1 mutation. So, if the individual is talking about what their germline
Germline.
RUNX1 mutation was, that's led to the RUNX1 FPD, I don't think that you would be excluded on the basis of the type of mutation, whether it would be a deletion or whether it would be, a single point mutation in the gene. And the reason for that is we don't know yet what the techniques might be for gene therapy in the future, right? Gene editing obviously would be a problem in a patient who has deletion of the gene, and that might not be the right approach. But folks are coming up with all kinds of innovative ways to do lentiviral gene addition as well, and that patients with germline inherited RUNX1 deletions, that type of abnormality might well be targeted with a gene addition strategy. So that wouldn't be exclusionary. What I did mean to say, and I did say, I think, is if you have acquired a second hit acquired RUNX1 mutation on top of the germline mutation, that we would view as very high risk for hematologic malignancies. And I think we would be very hesitant to enroll patients in this study if that were the case.
Apologies, I'm pretty sure they meant germline,
Right.
but thank you for that additional information is helpful. I was thinking about yeah, would there be a therapy in the future for this individual? And you answered that nicely. So logistically, maybe we could have counted them, but how many bone marrow biopsies will be required throughout the whole process of
Mhm.
the trial?
So if you are following the program guidelines, and Amanda, you can correct me if I'm wrong about the program guidelines, but the suggestions for regular clinical care for patients who have RUNX1 FPD are that you undergo yearly bone marrow screening to look for clonal evolution towards MDS, right? And if you are doing that, then we are talking about one extra bone marrow, right? Because we would hope to time your enrollment on this study with your scheduled yearly bone marrow evaluation. The extra bone marrow would be the one that is done at 6 months after the stem cell collection. And then you would be resuming your regular bone marrow surveillance at that year 1 and year 2 mark. So we're talking about one extra bone marrow biopsy on top of what is considered to be routine standard care.
I will say there are the clinical consensus guidelines aren't out yet, but I think they're leaning that way as 1 year is recommended. We see different, recommendations for depending on the patient, depending on the institution, but I think that's pretty standard and what we're going to see come out in the consensus guidelines. So that is a good way of thinking of this. Did you say, I heard you mention the 12 and 24-month follow-up could probably be done at home, but you would like the first two to be done at CHOP, or CHOP would like the first two to be done there. Is that correct?
Um, the answer is the 12 and the 24-month follow-ups could probably be done locally in their entirety. I think we would actually prefer just a follow-up, visit at
Yeah.
CHOP for the 12 and 24-month visits, just to check in. I think we're pediatric and young adult providers here, and we like that level of follow-up. But the bone marrows themselves don't necessarily need to have to be done if you were to come back here for a clinic visit, for example. So if it's easier to be done at home, I think that would be fine. And if it's really a burden to come back just for a clinic visit at the 12 and the 24-month visits, we could, in all likelihood, make something work at your home institution.
Great, thanks. Actually, I'm just curious, apologies, but I'm curious about the fact that you are a children's hospital offering this to 6 adult patients. Is that an anomaly or is that something that happens periodically there for different studies?
20 years ago, I would have said that's an anomaly. In the era of gene therapy, this is common. So all gene therapy trials that we've had open to date have all started with only enrolling patients who are 18 and up, based on those same principles that I outlined in the one slide, as to why that's our IRB's view. And so, across the span of conducting gene therapy trials here, have been treating patients into their 20s and their 30s routinely. Once we get into the 40s and 50s, we can talk about that a little bit more because, interest of full disclosure, we don't have much experience in those age ranges, but it's pretty commonplace for us to be talking gene therapy to young adults.
Okay, good to know. Thanks.
Mhm.
Okay, what is the percent of patients that end up needing a central line placement? Do you have a rough idea?
I will stand with the more often than not is, I guess, what I would say. And some of this comes down to um, what our goal is. If our goal was only to get the autologous backup, which, if you remember, is the 2.5 million cells per kilogram, it's likely we could do the apheresis, or this specific type of apheresis is called leukapheresis. So I'm going to use that term. It's likely we could do that just with IVs in the majority of patients because that isn't that many cells to acquire. But if we are really shooting for what is one of the main objectives of this, which is to try to collect enough stem cells that you might be able to use these cells in the future for a backup, or for a gene therapy product, excuse me, not the backup. Um, I think it's our experience from doing a lot of collections for patients with gene therapy is that IV access alone is usually not adequate to get those, because you're not able to run the circuit well enough and for long enough to be able to get those numbers of cells that we're talking about. Um, so, it can be an individualized discussion as to how we go about that. How about we go assessing for that, but I think that would be my take.
Okay, that makes sense. That's great. Um, so someone says, I have multiple relatives who could be candidates for this study. Is there an IB available from CHOP or MD Anderson to understand these studies in more detail before I recommend to them? I think you might mean a brochure,
An
informational
investigator's
brochure.
brochure.
Yeah. Okay.
Yeah. Because this isn't an industry sponsored study, we don't have investigator brochures in the same way that you might be thinking of having industry sponsored studies, but we do have consent forms. And if we had a conversation, if you wanted to reach out to one of our coordinators, there are ways that we can get you those consent forms to take a look. But the investigator brochure is a little bit different. We can provide you with information on that level about the medications that we're using to do the mobilization. But if you're looking at the whole process of the study, an IB is a little bit of a different thing. So
Okay, sounds good. We can certainly send out, yeah, it's different, but the summaries that we have. And
right,
is there a
exactly.
clinicaltrials.gov entry yet for your study? Do
I
you
know we're
know?
actively working on it, but I don't know the
Yeah,
answer to that
okay.
if it's been posted or not. So
Yeah, we
yep,
can share what we have, of course, following this call.
yep.
But that, okay. Let's see. Well, I think you covered this on the deletion, if the runxo mutation, the germline is a deletion, might that impact feasibility for future gene therapy? I believe you said yes right now, but who knows what's coming, right? Deletion, you don't
It would
necessarily
be
see that
harder
on the
to
horizon.
apply gene editing to a full gene or a large partial gene deletion, just based on how gene editing works. But the strategy of gene addition, which is the one where it uses a lentiviral vector to insert a normal copy of a gene, that strategy could be applicable. So, I think you'd have to weigh, the pros and cons of maybe one avenue of gene therapy being less likely, but another being possible. We would not preclude a patient from participating, but I think that individual participant would, should really think about that before they decide whether or not they want to participate.
Okay. And then the follow-up on the other, so on the person who asked about the IB, they were hoping for perhaps then maybe a more detailed one-on-one discussion, which I think is a great question. I think that's something that your team is willing to offer.
Sure, absolutely.
As
Yep.
patients are interested, correct? Who is the best person for me to send patients to on your team? Would that be, you had mentioned Nora? Nora? No,
I,
probably not
I
Nora.
actually think I should provide you with another contact for that sort of information. But our transplant team coordinator is actually the person that would be best suited to being able to set up that one-on-one consultation. And I can provide that information for you and then send out to interested parties. So if they would be willing to connect to us through you guys, we can get that information if that works.
Yeah, I have a feeling this person will be fine to do that. But I'll reach back out and we'll discuss. And then I think the final questions, if anybody else has any other questions, feel free to drop them in the Q&A. But the final one I see is, oh wait, no, two. How do we test for a second hit in the Runxo mutation? Is that through a bone marrow biopsy done prior to starting the trial?
Absolutely. So that's the screening bone marrow that we do in those 90 days prior to you coming in for the apheresis collection. So we would be doing genetic analyses on that bone marrow that would look for any of those genetic abnormalities that we would consider to be an exclusion.
Okay. And I'll just mention that anyone on this call who's had a bone marrow biopsy done with their teams, I believe could ask if they have any hits now, right? Like in theory, that's something that you could know currently, but certainly that's part of you, Dr. Olson, wanting to get another one done within 90 days, right? Ahead of time. Yeah.
Exactly. Yeah, I think the reason for the 90 days is we know that these things evolve, right? By definition. And so we just want to make sure close to the time that you undergo this, that your individual risk benefit is in favor of going through with the study intervention.
Yeah, great, thanks. Okay, and then that final question, because I don't see any new ones, is would participants have to pay for travel and lodging? And my comment from us is that the RRP has been able to now secure funds that we can offer support. If you need help, we can offer support for travel and lodging while at CHOP visiting for this trial. So we can discuss that offline. Definitely, if you're interested, please reach out to me and we can discuss what that looks like. And then this individual says also, thank you so much for all of this. Your work gives us patients so much hope. So.
We greatly appreciate your interest in those sentiments. I think we're working with the same goal in mind, which is to come up with better strategies to prevent and treat malignancies that come up in RUNX1.
Yeah. Okay. Well, I think that comment sums it up well, how we feel about your work, Dr. Olson. Thank you so much for being here today and all the time you spent on this and all the time you will spend ahead on this work. We really appreciate it.